Hello, and welcome to the next UCARE LevelUp video series. It's delighted for us to be contributing to this video series from the University of Cape Town and our UCARE and ACARE centers here in South Africa. I've got the pleasure to be joined today by a close collaborator and colleague from dermatology at University of Cape Town, Dr. Thuraya Isaacs. Hi, Thuraya.
Hi, Jonny. And it's lovely to actually be able to join this today.
Excellent. And today we're going to chat about comorbidities in chronic urticaria, and really just to raise awareness about these important links and to highlight that people need to think about this and to do efforts to diagnose and treat these associated conditions. The concept for most of this video series comes from the 7C concept in chronic urticaria. And you can see here, there's been already videos and great data presented by colleagues from around the world on confirming the differential diagnosis, looking for common urticaria, autoimmune markers, identifying and trying to isolate potential triggers, and then as well looking at the consequences and the course. Today, we're going to, of course, focus on the comorbidities. So, Thuraya, what is your first investigation or the first group of conditions that when you have somebody with chronic urticaria, you really like to talk about and think about?
Thanks, Jonny. I think that thyroid autoimmunity is the most common comorbidity that we really see in CSU. And there have been large systematic reviews by Co-morbidities that have shown that hypothyroidism, Hashimoto's, is actually more common than hyperthyroidism and Graves', although both of them are common in CSU, with prevalence of about 10% for hypothyroidism and 2.6% for hyperthyroidism from an Italian population study. What Co-morbidities systematic review did show that it commonly occurs in females, adults more than children, and that besides thyroid dysfunction, the IgG antithyroid antibodies are also elevated in these patients. And then IgE antibodies maybe to a lesser degree. So looking at the IgG antithyroid antibodies, it's the antithyroid peroxidase that's actually more elevated than the antithyroglobulin. And I think where this is important is that these antibodies can actually be elevated many years before they actually develop thyroid dysfunction, even up to 10 years before developing thyroid dysfunction. So when you have a patient with CSU, you should be screening for thyroid disease, taking a good history, doing an examination, doing your baseline labs like your full blood count and your CRP. But for specifically for thyroid, we'd recommend the TSH and the antithyroid peroxidase or the antithyroglobulin if you've got it available. And actually in patients who are subclinically hypothyroid, to actually screen them annually, because it might take up to 10 years to actually develop that thyroid dysfunction.
Yeah, and I think that what's interesting is obviously in thyroid autoimmunity, there's a great overlap with where we're moving in terms of biomarkers of different mechanisms in CSU. So, you know, splitting out the autoimmune type 2B phenotype from the sort of autoallergic phenotype, and these antithyroid antibodies seem to sort fairly well with the type 2B phenotype, and definitely I would agree with you about the TSH screening and approach to that.
So, Jonny, what about other autoimmune diseases? It can't just be thyroid antibodies that we screen for. What do you do in your practice?
I agree. So, yeah, thyroid autoimmunity in a way is just the sort of tip of the association in terms of the tip of the iceberg. And we definitely screen broadly across the board for autoimmune diseases. And it's not uncommon actually for patients with chronic urticaria to develop another autoimmune disease, and sometimes even more than one of those. And this tends to happen in the first 10 years after the chronic urticaria diagnosis. And the biggest sort of associated studies come from large patient groups. Like there's this study that we're quoting here, which is an Israeli study, which looked amongst 12,000 patients with CSU compared to a control group of about 10,000 patients with other dermatological conditions. And here what they noticed was increased odds of vitiligo, of rheumatoid arthritis and Sjogren's. And the odds ratios here are high, sort of 17 to 20-fold higher chances of getting that compared to a non-chronic urticaria population. And then in addition, there's also associations with celiac disease, diabetes, and of course, lupus. Now, I put at the top here that these relationships are more common in females with chronic urticaria, and I think that is worth noting. What about sort of diagnostic laboratory stuff? So the other thing that was highlighted in the study was that patients with chronic urticaria have increased positivity of both rheumatoid factor and anti-nuclear antibodies. And so we will often, if patients do have any kind of suggestive symptoms, we would definitely screen for some of these autoantibodies. And then, like all autoantibody testing, it's really important that you contextualize this within the context of other symptoms or the clinical characteristics that make up these different autoimmune diagnoses. So that's kind of autoimmunity, Thuraya, but the other big group is really the issue of mental health. And I think we have got increasing awareness across the world about mental health issues now, but our chronic urticaria patients are a really special group. And so how do you approach mental health issues in chronic urticaria?
Yes, Jonny, I agree. I mean, chronic spontaneous urticaria has a profound impact on patients' quality of life. They don't sleep well. It affects their ability to perform at work and at school. Large systematic reviews by Constantino actually found that 1 in 3 patients with CSU may have a psychiatric comorbidity. And these comorbidities can actually vary from insomnia to anxiety, depression, obsessive compulsive disorder, substance abuse. So it's quite a vast degree of psychiatric comorbidities. What we don't know, though, is whether the psychiatric comorbidity actually precedes the chronic urticaria, whether it's just coexistence or whether it's a consequence of the CU and the impact on the quality of life. There have been some studies showing that psychiatric comorbidities are linked to higher disease activity, especially depression. There's also been 1 to 2 studies showing that treating the psychiatric disorder might improve the chronic urticaria. So, when you see your patient, I think it's very important that we actually look out for mental health issues, that we recognize these and refer these patients if needed.
And of course, as you touched on there, what's interesting, and this is true of some of the gastrointestinal conditions as well, this link between psychiatric illness and chronic urticaria, of whether it precedes or whether it coexists, is a consequence of, is I think also something that's very interesting for us to consider. And I think it's an area of ongoing active research. Do you see any patients or will ever look for inducible physical urticarias, Thuraya?
So as a dermatologist, I mean, we might see the inducible urticarias, Jonny, but we don't really have the sophisticated equipment that you have in your center. So could you tell us what testing you would do for these patients in your center?
Yeah, so I think, the first point, I guess, worth making here is that when you see somebody with chronic urticaria and chronic spontaneous urticaria, it's very, very important to ask them specific questions. And history still remains key to trying to elucidate patients with physical urticarias. And you can see from this lovely graph that we put together in our recent Nature Primer article, we've highlighted here all the studies that have looked at the relationship between chronic urticaria and comorbid chronic inducible urticaria. And you can see that somewhere between 1% and up to even 40% of patients with chronic urticaria will have a comorbid chronic inducible urticaria. And if you look at this table, you'll see clearly here that the commonest of that is in fact a symptomatic dermatographism. One study found that delayed pressure urticaria was also very common. And that's something that is an interesting one, because you always need to ask, when you're carrying a heavy bag, there's often a time delay between when you develop the swelling and when you were carrying the bag. So that requires some teasing out on history. And then the other group that I think really is important that can cause quite a lot of morbidity to patients is relationships to cold. And in our Cape Town winters, things get cold here. There's a lot of rain, and often there's a link between the cold temperature and the rain. And so I often, start by asking all my chronic urticaria patients about those physical symptoms. We've been fortunate enough now at our UCARE center to set up the more standardized provocation testing, including simple tools such as the Frick test and also the temperature testing. So I think that, details on those provocation testing have been covered in another webinar. And I guess from our perspective here is just really to alert people to ask about chronic inducible urticarias when you're sitting with somebody with chronic spontaneous urticaria. And also probably even a more common problem that I get faced with as an allergist is that people with urticaria get referred to me with long lists of foods that have been triggering their symptoms, or other exogenous allergens from the environment. And I think that one of the commonest things that I do for patients is actually make the diagnosis of chronic urticaria. However, there is actually a relationship between the two. So there are about 3 large studies that looked at the relationship between chronic urticaria and atopy or other allergic diseases. And definitely those 2 diseases can coexist. And so you do need to be alert. So even though, you might have your typical symptoms of 6 weeks of urticaria or longer without obvious relationships to exogenous triggers, and that will help you make this diagnosis of an autoallergic or autoimmune chronic urticaria, I think you do need to take a history about, does the person have a history of asthma? Do they have allergic rhinitis, or do they have eczema as a child, or even currently? And then there are a few kind of what I would call red flags for making sure that when you are thinking about urticaria, that you do then potentially look for a particular triggering allergen. And the one would be a clear temporal relationship. I always eat these fruits, and, shortly thereafter, within the first an hour or so, suddenly I've developed urticaria. The other thing would be intermittent symptoms. So we do sometimes with chronic urticaria see episodic symptoms, a period of time where the person is worse and then they're better. I think that when I see that in my practice, I often try to tease that apart to see whether there aren't then actually, potential triggers that we are missing. And then I guess the other red flag is that, chronic urticaria is a skin and mucosal surface disease. It should not give you bronchospasm. So if somebody gives a history of having urticaria and then also developing bronchospasm, or for instance, going on to full-blown anaphylaxis, obviously that should prompt more detailed investigation for allergic disease. But I think that, certainly that's a very common presenting aspect to me as an allergist. But, moving back and maybe throwing the ball back to you, Thuraya, the other group that I am always struck with in chronic urticaria is how common, especially amongst the severe patients that I see, is the problem of obesity and elevating BMI. So I know that there's quite a lot of research. Do you want to comment on what your approach is?
Yes, Jonny. So there have only been recent studies actually looking at obesity and metabolic syndrome and chronic urticaria, even though a lot of our patients that we notice in the clinics with severe urticaria are obese. So there was a study, an Italian population study, that showed an increased prevalence of obesity in chronic urticaria. And then this table that I've got up here is actually a study looking at metabolic syndrome in chronic urticaria, and they found that metabolic syndrome was prevalent in 30% of the populations of the chronic urticaria patients. Also that the presence of metabolic syndrome actually resulted in poorer clinical outcomes. So these patients had much higher urticaria activity scores and had a more severe disease course. So they actually had less remissions than the control populations. And what they also found was that the metabolic syndrome itself is an independent predictor of uncontrolled chronic urticaria. So clinically, if you've got a patient with uncontrolled urticaria, you really should be investigating and evaluating for metabolic syndrome. And obviously, if we find metabolic syndrome, or if we have a patient who's obese, we should be recommending lifestyle modification, even though there isn't really any evidence that it might improve the chronic urticaria itself, but we know that it will have benefits in the long run for the patient in terms of cardiovascular morbidity. And then actually having said that, there is no real evidence at the moment that chronic urticaria is associated with increased cardiovascular disease. But despite that, it's still important that we actually look for metabolic syndrome and advise lifestyle modification because of the other health benefits.
Yeah, I totally agree. And of course, there is data across different inflammatory diseases that, you know, adipose tissue is inflammatory. It's pro-inflammatory. And I think that certainly that is potentially a contributing factor to the overall inflammatory milieu within the context of chronic urticaria. And what about, you know, I sometimes see a kind of older group of patients with new onset chronic urticaria, and it always makes me think, oof, is this a paraneoplastic presentation of chronic urticaria? So I wonder, like, you know, what is your approach to looking for cancer in the context of chronic urticaria?
So the studies are very inconsistent, and it's controversial whether chronic urticaria is actually associated with cancer. There was a large population study that found no association, but subsequently there have been two other studies that have shown an association. So the Taiwanese study actually showed an association with hematological malignancies in chronic urticaria. And then there was a Korean study that showed the complete opposite, that chronic urticaria was actually associated with non-hematological malignancies, such as stomach, thyroid, liver, and prostate. So I think the key thing here is that you should actually be going according to the patient's symptoms. Take a good history. If your patient has got loss of weight or any symptoms suggesting a malignancy, then you would then investigate it further. But at the moment, there's actually not enough evidence to suggest that we should be screening routinely. So what about gastric diseases and Helicobacter pylori, Jonny?
Yeah, so I mean, look, I think that the relationship between chronic urticaria and the GIT is a fascinating one. And certainly there's quite a lot published about almost potentially a bidirectional relationship that, there might be uncontrolled chronic inflammation in the GIT, which drives, and increases the likelihood of chronic urticaria, although the relationships, I think, are complex and the data conflicting. But just looking purely at the association level, there's definitely a link between chronic urticaria and an increase, especially upper GIT problems, peptic ulcer disease, autoimmune gastritis. There's that link I mentioned earlier on with celiac disease. And I think that importantly, and certainly like in our context, you'll be familiar with this, we have such high rates of H. pylori infection within our South African population that I routinely look for H. pylori infection. What's interesting is that even though we live in an environment where there are other parasites, we very rarely find other parasitic infections in the context of chronic urticaria. And outside of clinical trials, I've actually taken to stop screening for parasites within my routine clinical practice, unless there's a particular symptom, a GIT symptom or history that flags up that this is important. I do think that the H. pylori is something that I would screen for, mainly related to the background prevalence of H. pylori in South Africa, which is very high. And also, even though there are conflicting reports on eradication. So, there was a meta-analysis which didn't really show that eradicating H. pylori made a difference to CSU. There's been some more recent publications which suggest that in about 1/3 of patients, eradicating the H. pylori may actually have, especially early on, a treatment benefit. But certainly, and this is also in the guidelines, the current guidelines for urticaria, is that H. pylori eradication has other benefits, right? It lowers the risk of GIT malignancies down the line. So I think certainly as a kind of general strategy, I think it's worth doing. And I counsel patients that it may have some benefits. I think what's fascinating is where there is, for instance, infection, that sets up gastrointestinal inflammation. And sometimes when you treat the infection, you may not necessarily stop the underlying gastric inflammation, or for instance, even there's a link even with gallbladder inflammation. You may not be stopping those, even though you've got rid of the bugs that were driving it or inciting it initially. And it might be the ongoing abnormalities of the GIT tract that might be causing the urticaria. And I know there's also some lovely data around gastric permeability being altered in the context of these patients. So certainly for me, this is my approach to the GIT tract in chronic urticaria. And I spend quite a lot of time unpicking that. I think the other thing, obviously, in the context that we work in South Africa, where we have this huge burden of HIV, and as well as hepatitis. So we have this great burden of other infectious diseases, particularly these chronic viral infections. One of the things that struck me is that we, and I think you share the same experience, that we just haven't seen an association of chronic urticaria with these chronic viral illnesses like HIV. I don't feel like I see a disproportionate burden of that. And so I don't think that really these chronic viral infections are a major a driver of chronic urticaria. However, if you look in the literature, there have been associations with, sort of chronic dental infections and or nasopharyngeal bacterial infections. And I think that, any active infection can certainly cause, innate immune activation and can potentially aggravate or exacerbate chronic urticaria symptoms. More recently, in the last 2 years, obviously, we've been very interested in SARS-CoV and COVID-19 disease. And in fact, an initiative from the UCARE networks has been bringing us all together to study this relationship. And I think there's been some very interesting early data that's come out. Firstly, acute urticaria, and infections are probably the commonest drivers of acute urticaria, has definitely been seen and associated with SARS-CoV-2 infection, as well as with both the mRNA and the adenovected COVID-19 vaccines. Fortunately, most of that resolves very quickly and is acute and doesn't develop into chronic urticaria, although there have been some case reports, and we've described a case series as well of chronic urticaria following COVID-19 vaccination. But if you look actually at the starting point with a chronic urticaria cohort of patients, what we saw was that about 1/3 of these patients exacerbated with COVID-19 infection. And I know that Emek Kotaturk has been leading this COVAX CU initiative, and we've got some additional data which has been presented elsewhere on the relationship with vaccination and also exacerbation of COVID-19, of chronic urticaria. I think on the whole, the overwhelming sort of leaning is that there's a benefit, that there's a huge mortality associated with COVID-19 potentially, and the data strongly supports vaccination and the fact that most of the time exacerbations can be fairly easily managed in chronic urticaria patients in this context. But I think it's been an interesting opportunity to explore the relationships between these two diseases. So I guess we've now covered most of the kind of spectrum of screening for different comorbidities within the context of chronic urticaria. But I think just to end with, maybe you can summarize, Thuraya, for us what you have in your practice, your approach to managing these comorbidities within the context of chronic urticaria patients.
Jonny, I mean, I think, recognition and diagnosing these comorbidities is really the first step in managing them. In terms of the thyroid disease, you would treat the hyper or the hypothyroidism depending on the actual clinical and biochemical abnormalities. And regarding psychiatry or psychiatric issues as well, you would treat them as per the usual treatment guidelines for depression. In terms of, what was the other one that I did?
In terms of metabolic and obesity, metabolic syndrome.
Yes. In terms of the metabolic syndrome and the obesity, obviously, I mean, lifestyle modification is important there because it has other benefits. We don't know enough that it will actually reduce the chronic urticaria, but it still has other health benefits, and therefore we should still be treating and advising on lifestyle modification.
Yeah, and I agree. And I think if you look at our guidelines for urticaria at the moment, especially again for things like H. pylori eradication, I think it's all consistent with, especially when there are other health benefits, we would probably favor treatment for those conditions. And then in addition, if there is a specific condition, as you say, like a thyroid, you actually treat it based on those biochemical abnormalities according to guidelines. Similarly, if you get a diagnosis of autoimmune rheumatoid arthritis, you would treat it as per those guidelines. So I think, thank you very much for joining us. I think that ends our webinar this morning and Level Up chat. I hope that everyone has enjoyed learning about these chronic morbidities and comorbidities, and will now look harder for them and treat and manage them in their chronic urticaria patients moving forward. Thank you very much, and goodbye from Cape Town, South Africa.
Thank you. Bye-bye.